Okay, so just like a quick review of leadership and delegation, I think probably the most important stuff from the notes are understanding. So the RN, when it comes to delegation, transfer responsibility and authority for the performance of an activity, but they remain what?
Responsible,
Responsible, accountable.
accountable.
Same thing, pretty much. All right, so then the five rights of delegation, what do we got here? That may or may not come up. It might come up. It'd be a random shadow.
The right person, the right task,
Yep. What else?
the right circumstance. Um,
Or you're thinking of the five rights of meta administration. This is five rights of delegation.
Delegation.
Loves, yeah. Right direction. I think it's like called right communication, like right like make sure that you properly explain like, hey, I want you to give me these vital signs. Also keep in mind this patient is blank and blank.
Oh yeah, and then the right person too, right?
Yeah,
Yeah.
I think that's right.
Yeah. Well, yeah. Right direction, task, communication, and supervision, evaluation.
Yeah, so that's that supervision. So it's not just delegate and then just be like, oh, like if they ask you what's the eyes and nose, you go, oh, I made my CNA do it. I haven't really checked. Like you also want to come back and see what's going on, see that they do it, that they actually do it. That's part of your responsibility that you made sure that the person that you delegated did what they were told to do. So that's kind of where that comes in.
Can't say 1-800 not my problem,
Yeah.
unfortunately.
So what are some tasks the LVNs cannot perform according to what we have here? Sure. I mean,
IV
yeah,
pushes?
they definitely can't do like IV stuff. Or, like they can't do IV piggybacks, I believe. No IV pushes.
No IV push.
I don't think they can even do IV starts.
I need
But
to
I'm not
double
sure.
check that one.
Yeah. Yeah, they definitely cannot. They can't do they can do assessments, but they can't really do interpretation of assessment. You can have your LVN lung sounds and then tell you what they heard, and then you and technically like use the RN, then decide, yeah, keyword comprehensive. Then you're the RN makes basically the interpretation of it. And you'll probably be like, oh, you heard crackles? Let me go in there, let me listen. Oh, I also hear crackles. Okay, let me do blank and blank. Blankety, blank, blank, blank. What else can they not do in particular? They can't do evaluation. Uh,
No teachings.
oh, sorry, I wrote the wrong thing. They can't do basics. They can't do like,
Initial.
yeah, they can't do like initial
I think
assessment.
somebody said initial.
Yeah, or
Because
comprehensive.
for what they teach here, they're teaching that the LPN cannot do the initial teaching, but they can reinforce teaching.
Yeah, exactly. So here, yeah, like she said, LVN cannot do initial teaching, but can reinforce. That's probably key. So you'll probably have questions where um you might have like a SATA and like one of the options is oh, have your LVN initiate teaching for patient learning how to do injection shots or something. And had it said like reinforce, then it'd be fine. But if it is like the initial teaching, then they can't do it. Pretty much it.
That's all they go over at
Yeah.
this point.
There's three things in particular that they said cannot be evaluated. We did talk a lot about it though. So that kind of goes in with assessments, evaluations, and judgment. So this is kind of like your general like comprehensive assessment, your judgment, and your evaluation. Not be delegated. That's your job.
I like there was one like saying
Yeah.
where it's like, you can't delegate what you can eat. So it's like your evaluation, your assessment, and your teaching.
Oh, cool. I like
So
that.
I like that one as like a general one. Oh, UAP cannot delegate LVN and RN can? Technically, yes.
Yeah.
Yeah.
So the RN can delegate to the LVN, the UAP, the LVN can delegate to the UAP, but the UAP can't really do, they can't, delegate to another CNA, for
Now, the
example.
one thing to say on that is you cannot delegate. If you're like the LVN, they can't delegate what has been delegated to them. So, for
Yes.
example, if the RN says, "Hey, LVN, can you do my vital signs?" and LVN then goes to the CNA and says, "Hey, do the vital signs." Technically, that doesn't, you can't really do that because it's already been delegated to you. I mean, that's just an example of something, but if you've been delegated a task as the LVN, they cannot redelegate it somewhere else. Same thing with the CNA. The CNA's been delegated something, you're technically not supposed to go to another CNA and be like, "Hey, do you mind doing this for me?" So don't delegate what's already been delegated.
Yeah, although I'm sure it happens in real
It
life,
does. Oh,
like a lot,
oh
but,
yeah.
and based on, academia, you're not supposed to.
Vital signs are in the scope of all of them. I just wanted to give an
Yeah,
example.
yeah. Let's see here. Another thing is that the RN can delegate like direct patient care activities to meet basic human needs, feeding, drinking, positioning, ambulating, grooming the patient, toileting, dressing. But you have to also keep in mind some activities that might be included in this list might not be appropriate to delegate if it might require you to do some sort of assessment first. So,
What's an example of that?
yeah, like, yeah, sure. I can ask, what do you think is an example of that?
If patient is just post-op and you want to do a feeding, but you probably want to assess first and do your initial feeding.
Yeah, pretty much. Like, yeah, pretty much. Like,
Right.
if going into the room to give them feeding would require you to find out more information, assess and evaluate, then the CNA isn't really appropriate there for them to the ones to be doing the vital signs. If someone just came back from like a procedure and you need to do the vital signs every 15 minutes after they come back from like their procedure, then it's gonna be more appropriate for the nurse to do it.
Yeah. In a more chronic, so to say, state, they technically are teaching here as well that for the feeding and drinking, if the patient has dysphagia, then technically, quote unquote, technically, like CNA is not supposed to do it. Is it going to happen still? Yes. But the rationale of like why they're teaching here, yeah, they want a LVN or RN to do it. More likely RN per book because they want you to be assessing for signs and symptoms of this person has dysphagia. So that's something you'll have some situations where you have these are your general things that you can delegate, but there are certain circumstances where it's like, this might not be the best task. This might not be the right task or the right circumstance to give this task or give this assignment to this person. So just something to keep in mind.
All right. So other things that the RN can delegate is like collecting, reporting, documenting data. So I can tell the CNA, do their eyes and nose. They have empty their Foley catheter, figure out how much is in there, put it in the computer. Um, Stuff like that. Get the vital signs, stuff like that. You can delegate. Any questions on this so far? This is just like basics. Yeah, pretty much. Essentially, yeah. Just like the basic stuff. For delegation, that I think is the most important.
For supervision, like if you do say like, oh, my CNA, can you go and do the eyes and nose? You want them, you want to give them a specific direction as well with it. What is that called for you guys? Oh, direction and communication. So, hey, can you do the eye and nose for patient in room 35? And if you see like XYZ, can you come back and tell me? Or like, can you tell me how much you emptied after you do it? Or vital signs, can you take the patient's vital signs in room 2? But if the blood pressure is over this, can you immediately come back and report that to me? So like certain parameters sometimes, or just in general, like come back and tell me like what you. But if you have like a specific parameter where it's like, oh, over this, like I need to give this medication, like Maybe you need to give like a hydralazine if the systolic is over 160. So if you say, hey, if the systolic is over 160, can you immediately report that back because I need to give medication if that's the case. But yeah,
Yeah,
I think that's pretty much
pretty
it.
much it. For prioritization, pretty much you're always focusing on ABCs, what's going to kill the patient first.
That's
Which,
my saying.
yeah, that's what she says a lot. It makes perfect sense. So I think that's,
It does.
yeah. ABCs, safety, changing condition, that's another key one. So patient having a changing condition that can,
What are some keywords that you'll see for that, do you think?
yeah, sure. Go ahead and put in the chat. Like, what are some keywords that you might see that might be a sign that there's a changing condition, or the question is trying to be like, hey, this is a changing condition.
Okay, I like that. Like maybe altered mental status when
Sure.
they were ANO and then now restless. I like that as well because Brooks says restlessness can be what? Oh, oh, yeah. So your restlessness could be hypoxia or an oxygenation issue deteriorating. So they had a condition, and there's you see in the question maybe it says like deteriorating of whatever this thing is that you're assessing. Um, Another one that I don't see mentioned yet, but they like this one a lot. Sudden,
Sudden. Yep.
sudden. So the patient has a sudden drop in blood pressure to whatever the case might be. Patient has a sudden change of level of consciousness. They have a sudden deterioration of this. Oh, that squeak. Yeah, so but they want you to know like the key words to make you think, oh, this is a
Yeah.
changing condition. So they like to put certain keywords that will make you be like, ah, yes, this is changing condition. Maybe I should look at this
Yeah.
person.
So I believe you guys had like either in class or maybe as homework, there were some prioritization questions, and I think one of them was like a patient has myasthenia gravis, I think it was, and something suddenly happened.
Oh, I'm surprised you remember that. I do not
So I
remember.
think that's like an example of one of those. Assuming you guys had the same thing.
I think they did.
Yeah,
That's
and
not that
then
you.
other than like ABC safety, change of condition, there's always like infection, but it's not towards the top of the totem pole before making sure that the patient is hemodynamically stable as well. And then pain is also not a top priority. Um, Unless you manage to clear everything else out, you're like, okay, now we can focus on your pain. Another one that's not even here because it's like the absolute lowest part of the totem pole is psych. So you guys just had psych. So here I'm gonna tell you, it's always like the least important thing. You don't focus on psych before you do any of the other stuff. You always want to think about stable versus unstable. Naturally, a stable patient is going to be less of a priority than someone that's unstable. If someone has unstable, can be that changing condition, can be
What else can unstable be besides that? So I want you guys to consider what patients, examples of patients that could be unstable. The post-op,
yeah.
I don't know nothing about. They were off the floor. I don't know what happened in there, and they just got back. So I don't know what happened. A new admit, I don't know nothing about this person. Yeah, possibly a transfer as well, because I haven't seen this patient, trauma patient as well. Oh yeah, oh, they're unstable. Maybe infection if it leads into they start to have like signs of sepsis. That is definitely something that is unstable at that point. Um, but yeah, just basically someone who you haven't laid eyes on a lot of the time. Or you laid eyes on them, they left the unit and now they're coming back. Anyone in or like a DOU?
Mm, not necessarily, but they might be. They could be.
Oh yeah, your ICU is always gonna be
Yeah, I
so
see you
unstable.
definitely.
Yeah.
Yeah, for 24 hours after the post-op, they're considered unstable. And of course, unexpected versus expected. So that might require a little bit of knowledge on the condition.
Oh yeah.
Is it expected that
COPD?
yeah, like a COPD patient has shortness of breath and the high respiration rate, versus not happening on someone with
Asthma.
yeah, no,
Eh,
well,
well,
that's kind of
asthma
is
attack. If they're
asthma
having
attack,
asthma
yeah.
attack.
Versus like, let's say a patient had a fracture of their a femur, if they're having shortness of breath and like sudden tachycardia, they might be
Oh,
like a
yeah.
yeah, like a fat embolism, DVT, yeah.
And that thing is moving up and into not too good places. That's going right into our circulation. That's going to cause a PE or pulmonary embolism. So when I see someone with, a fracture in some part of their leg, and all of a sudden they're like, I can't breathe. I'm like, oh, that's definitely not
Yeah.
supposed to be there.
Yeah, that's not
That's
supposed.
unexpected.
Yeah. Is it a probable complication? Yes, but is it happen with everybody that has a fracture? No, so that would be like unexpected.
Pretty much, yeah.
Yeah, so that's how you can kind of tell the difference between. Next, is it acute or is it chronic? Obviously, if something is chronic, it's something that's by definition can be a little bit more stable versus something that's just kind of suddenly happening. So again, that word suddenly comes up a lot. So acute versus chronic. So a lot of these can even be like overlapping a lot of the time. Um, Actual versus potential. Is there an actual issue going on, or is it a possible issue? On You focus on the thing that's actually there versus the thing. Instead of fighting, don't like fight the ghost. You gotta do what they're for. Hey, that's like a phrase, no?
Yeah. So like, for example, like maybe back to the infection patient, like that person has a potential for becoming septic, but in actuality, let's say that they're not septic. So that person would be a little more stable. Well, not, I don't want to say stable, would have a potential problem. Or sorry, if they had sepsis, then that would be an actual problem. But because the person with infection has the potential to have sepsis, that
Yeah,
would still be under potential, not actual.
yeah, yeah.
I'm trying
So
to think of another
pick
example.
another example, huh?
My brain kind of died on that one. It would be like basically your complications. So like, has the complication actually happened yet?
Hmm.
Like CHF exacerbation, are they having like pleural effusion already, or is it potential problem?
Or we can even go back on some of the scenarios you guys probably experienced in the CPE.
Mm.
Maybe like again, someone like on a trach with high blood pressure. You want to do your ABCs, but you like and like with a trach, like maybe like a trach and the patient having in the past like secretions and maybe yeah, pretty much. And having like issues with their airway, use like, oh, airway goes before circulation. But in that scenario, they were clear. So even though it's a potential issue that they might have airway problems, in that situation they don't. And the actual issue is the blood pressure, right? So that's like actual versus potential. Technically, the ABCs go before the circulation, but in this case, they're not having problems with their airway or their breathing. So focus on the actual problem.
Yeah, that's what happened in mine. I know that technically it wasn't be that order, but I rationalized it out. So it's
Yeah.
so important to talk through anything that you're thinking in your CPE. Because like, I guess technically you're supposed to
Yeah.
suction first, but
Yeah. Do you think we can talk about it? I mean, they already had their CP again, and they're gonna
everyone's done it,
and they're
right?
gonna have different scenarios.
Oh, for the second one. Yeah, I was
Yeah,
like, she said yes.
yeah,
Oh, yeah.
yeah. So basically, what happened with her CPE? She had stereotypical suction versus high blood pressure. It's your story, so if you want
She
to,
said it's my
yeah,
story.
your story, girl.
But yeah, so like, typically we're looking at, oh, I need to suct in this patient first because I'm worried about their oxygenation. But then when I did my assessment, and sometimes they change stuff up. But from what I determined, the patient oxygenation and airway wise was doing all right. Like they were at the cusp of needing to be suctioned. Like they'll say like, oh, if they're under, let's say 92%, then you're gonna suction. The patient was like at 92%. I was like, oh, we're teetering here. But technically they didn't meet full criteria. Whereas for the blood pressure, yeah, I was like, I forgot the number that was there. I'm kind of just spewing it, but they basically didn't meet the criteria yet to suction. Whereas opposed to the other um tasks I had to do, they met the criteria for the medication administration. So as I was talking through, I'm like, okay, I want to do the medication first because it was like their blood pressure. I was like, if I suction them too, like oxygenation wise, they're fine, blah, blah, blah. And I went through that. And I was like, well, their blood pressure, I don't have anything else on board per the report that I have no other meds for blood pressure. And when I suction them, their blood pressure is also going to go up. So I was like, I knew that they were clot risk. I knew, I forgot beyond that, but like, I just remember being like, yeah, I should probably, do this first. And my instructor was like, okay. And like,
Yeah.
we moved on with
Yeah,
life.
because I think also you also said it was like so they were like at the cusp, but they did have some lung sounds, but they weren't symptomatic.
Then they're also, per report, were suctioned just 2 hours ago. So I knew, yeah, CP is definitely fun. And they do change up the scenarios like per so my scenario with the numbers that I was given might be different from the numbers that other people were given, and that affects what you do first, how you prioritize, or what do you like, even what actions you end up doing. But
Yeah. Meanwhile, my CP was I was doing the most, and she's like, "Oh no, it's okay. Just okay. No, you don't have to lift the mannequin up. It's okay." I'm like, "Oh, let me just check if they have socks on."
let me check if they have socks on.
She's like, "No, it's okay." I was like,
Bro, that's so
and
extra.
then my skills was literally just what was ordered.
I love that for you. 10 out of 10.
That was funny.
That's hilarious. Okay. Moving on from that though, where did we leave off?
Yeah.
Systemic and local?
Yeah, systemic versus local. So
Okay,
naturally,
back to
yeah,
infection.
back to infection. Like, what's gonna kill my patient first? What makes like is it infection on your toe versus a
Septic.
sepsis? Right? So that makes sense, right? Or even things like maybe complications of like even like maybe like radiation, localized effects versus like a systemic effect from like chemotherapy. Um, just like it makes sense that we're worried about things happening throughout the body versus just a little thing on one area.
Like if I'm having a rash on my hand versus I have a rash across my chest, my face, and my legs.
Syphilis. I'm kidding.
Oh my
Well,
God.
maybe
I don't know.
the full body rash. Stage 2 syphilis. Oh my god.
That's gonna be more critical as opposed to I have just a rash on my hand. Like we still need to monitor that, but these are just examples. Um, but yeah, your systemic is gonna kill you before your local thing is basically what I'm trying to get at.
Pretty
Oh, and then
much.
look right there, patient new admit. We just talked about that too. Or just returned from a procedure. We didn't have eyes on the patient, so we don't know what happened in the procedure. We don't know anything about this new admit. So that's somebody that you want eyes on yourself. Yeah, we definitely want to evaluate or reevaluate. Like if they were on our floor and they left and they came back, we are definitely reevaluating that patient. Because Lord knows what happened off the floor.
Yeah. Yeah. And then anything where there's any doubt of stability, you should do it. The RN should do it. Because you're the person that in that scenario is the one that makes the assessments and the evaluations, as opposed to like your CNA can do their vital signs, but then there's something abnormal, then they have to go to you, and then you have to come back and do that instead. If you were just there in the room the whole time, you could have treated the patient initially faster.
Yeah.
Something again she emphasizes a lot is if there's restlessness and confusion, you want to think of it as hypoxia until proven otherwise, and then do an assessment, try to find out what's going on. When in doubt, you're just going to assess. Whenever you're in doubt, you're assessing. You do an intervention, then you reassess. That's just kind of like the main things. But then this is like a prioritization application from when we worked through the questions in class. So based on like the problems, pretty much if the patient is complaining about anything on her questions, we were saying that the patient's unstable. If they have complaints of blank and shortness of breath,
Chest pain.
yeah, you were saying, the patient's considered unstable. And then we're looking at other factors as well. Gotta take into account what is unstable for whatever thing, whatever is expected for whatever thing. If you're transferring onto unit, you want to think of it as unstable, it's unexpected, and a potential ABC problem. So anytime someone's a new admit transferring over, you really gotta put special attention to the person. You don't know anything about them. Again, if there's disoriented, you want to assume hypoxia, and hypoxia, in terms of the ABCs for the kinds of questions she does in class was like a breathing issue, unless proving otherwise. And then of course keep attention words like sudden, and when you're looking at your ABCs, anything in the neck area would be like airway, your general core, your chest, issues with that, hypoxia, breathing, and then circulations, everything else. And I know she talked about like the big C, little c. So like major circulation issues versus like smaller circulation issues. So trying to think of something. I think edema, she's like, oh, that's a like a little c. Like edema caused by like heart failure, like a little c versus um like a hypertensive crisis or hemorrhaging, which is like a big
Big
C.
C. I think she said hemorrhaging for the example that we got in our class.
Yeah. And another thing you can do is you can try to split questions into assessments versus interventions. So if you're doing a question and you feel like the question itself had enough information, then we can cross out the assessments. I don't need to assess anymore. I have enough information. I want to do an intervention. Okay. Any questions on anything we talked about here? If not, we can go through some of the questions we have.
Bro, the internet
Pretty
here,
straightforward, yeah. What happened?
the internet here is trolling.
Oh yeah, it's not
I'm
great.
struggling.
At least it's up though.
True. Do you want to go through that?
You can just look through it real quick.
I mean, it's pretty much what we talked
Yeah, it's
about, but
pretty much what
now
we talked about. Now
I
it's
was like, it
all
is pretty straightforward. It's just the application of it where things get a little wonked out.
yep. Here it's like, can you identify the topic? What is this question actually about? Are the answers assessment or implementation, aka interventions? Are they physical or psychosocial? If they're psychosocial, then we like ignore it. I'm kidding. We just don't
Bruh.
prioritize it over the physical. Are they ABCs? In which case you know how to prioritize with your ABCs. Um, think about what the outcome is with your answers. So maybe two answers are technically like proper interventions for your problem, but maybe one is more effective. If you could only, and then probably like one of the bigger things is like ask yourself if you could only do one thing and leave, what would I do? So if you have again if you have two good answers that you would like to do, but if think to yourself, if I could only do one of these two and then leave and not think about it again, which one of them would, yeah, what would
What's
lead
the
to,
better
yeah,
outcome?
what's the better outcome?
I like that. Because we
It's
do need to look forward, like if
yeah,
I do this thing, or if I don't do this thing, what is going to happen to the patient? What is the outcome of my intervention or lack of? I like it.
yeah.
I
So
like
like
it. Picasso.
if like, you could do only one skill and then you like had a stroke and died,
Bruh.
then you're which one of those kept your patient alive? No. Yeah, some common and clutch traps. Again, part of the Kaplan tree. Don't ask why. Don't leave the patient. All that stuff. Don't just do nothing. Try to do something. Therapeutic communication tips. Do not ask questions and stuff. The five rights. So again, the five rights comes up a lot. So keep that in mind. Yeah, this is just like another little thing. This is basically the Kaplan decision tree, but made into a single page, close to however long it is.
I don't know what happened to one of the questions, but it like repeated a part of it.
Yeah, you can fix that.
It's later on down the line,
Yeah.
so I'm gonna fix it right now.
All right. So then here are some of the questions we have, and as stated here, all of these are select all that applies unless stated otherwise. All right. So here, number one, you're making the patient assignments for the next shift. In your unit, there are three LPNs, LVNs, two RNs, and two nursing assistants. Which patients will you assign to the LVNs? Select all that apply. Let's see if we can get like at least like 4 people, at least 3 or 4 people to answer.
I think I fixed it for the most part. I don't know what happened there, but that was weird.
Remember that these are all status unless we state otherwise. I think that's enough good answers. So let's kind of just go through. So there were more yeah, so we can talk about that. So pretty much everybody though agreed that C and D makes sense. So a lot of the LVN questions like which ones can you assign to LVNs, a lot of the time it ends up being which one of the patients have are most stable, as well as maybe things that like their tasks for the patient involves like scheduled stuff, like daily, like a dressing, like a scheduled dressing changes or just
I was gonna say like procedures that are within the scope.
yeah,
of
within their scope.
Or
That
medications
yeah,
in the scope. I see
basically
that.
basically things that are expected, like very like routine stuff, like routine stuff.
Oh, I see what you're
Yeah,
getting at. Okay.
like routine stuff. So in this case, this person has relatively stable, or like they just and they have scheduled routine tube feeding, so the LVN is able to do it. This patient is not really expected to uh, have random stuff happening to them. It's just kind of stable, chronic, routine stuff. So the scheduled tube feedings. Yeah, so that's basically what we were gonna talk about for A, but we'll talk about D first. Again, this is just a patient who just has an order to remove a Foley catheter. Is that in the scope of the LVN? It is. So they're A, as opposed to B, which is a newly admitted patient. Not only is that not something we want to have on someone that's not an RN, but they also have like a DK, so they're gonna have they're gonna be very like a lot of like
They
unstable
need
condition.
frequent assessments.
Yep.
They're gonna have a frequent change in condition and you need to be titrating medication. So that's definitely something that
Yeah.
that should not be delegated to this person. This person is extremely unstable.
Yeah. And now, kind of like with Carissa, I believe it was and Ryan were saying. So Carissa did put A, and Ryan was unsure about it. So, basically, exactly what Josh said. Is that the patient is expected to be discharged home on IV antibiotic therapy. So one of the things we mentioned that the LVN cannot do is they cannot do initial teaching. So this patient needs to be instructed on things regarding to their IV therapy. What do you think is an important teaching that might want to be done for someone being discharged with antibiotics?
Teachings, initial teachings, and then you also want to tell them, like teach them about signs and symptoms of infection, what to look out for.
Their
But because
IVs.
he's stable, because he's gonna get discharged, it's like you're on the fence because they're
I see what you're
stable
saying.
enough
Yeah,
to be with the LVN.
I see what you're saying. It's just that again, the teach that's where the teaching parts. I remember in like here in the outline we mentioned some things that Alvin cannot do, and that's the initial teaching. So in that scenario, that patient needs to have discharge teaching, and they're not really going to be. So maybe like something that an LVN can do is maybe take care of a patient who is planned for discharge on a different day. Like they're planned for discharge tomorrow. They'll be okay versus they're going to be discharged in like a few hours and they need teaching on their IV antibiotics. What else it might be important to talk about with IV antibiotics?
I like what Josh IV signs and symptoms. How does it look? Is it clean, dry, intact? What to report? IV antibiotic involving maybe some dressing changes, flushing, regular flushing if it needs it, depending on the type of IV that they have.
Yep.
I think these are all good things to do. And a lot of times you'll have like you have IV antibiotic therapy, like being sent home. Yeah, your home health too. But a lot of times it's like a pick line. So now we're going into the realm of CBC's central lines. So there's definitely more cautious, I so to say, assessments that you need to do because there's more stuff that can go wrong, more critical things that could go wrong.
Yeah, and there's like another teaching that's important, which is antibiotics again.
Oh, gotcha.
Yeah.
Like, girl, what you talking about?
That could be one.
I'll go with that.
Basically, how do we prevent COVID?
Finish.
How do we prevent COVID-20?
Bruh,
That's finish the entire course, even if you feel better, exactly like what Carissa mentioned.
finish the entire course. What are you stressed?
Because that's like a common thing that some people is like, oh, I feel better. I'm not gonna finish the entire course, and now
Now
the
we got heckin resistant
yeah,
bacteria. Yeah, review all their new
sure, yeah.
medications that maybe they're getting sent home with additional things. Definitely want to do education on that, what the med is, why they're getting it, signs and symptoms, what to report, what to expect, what's therapeutic, et cetera, et cetera. Yeah, I think
Pretty
we drilled down this question as hard as we could.
pretty much. Oh, you had
This one's long.
this one's long.
Sorry.
So, as the registered nurse, which task below should you not delegate to the LVN?
Oh,
Yeah, what?
oh no, go on. Come on. Why'd you unmute?
Huh?
I,
Oh, I was wondering. I thought you wanted to
no,
talk about it already.
no.
Oh, I think we have enough answers.
Okay.
Yeah.
Go right for it. Go ahead, chap.
Okay. So we all pretty much agreed that we're not gonna have the LVN do assessment on a new admission. So that's kind of immediately something we directly talked about. So yeah, it's we're gonna say it's gonna be A. Um, collecting a urine sample from an indwelling Foley catheter, that's perfectly fine. They can do that. Yeah. Let's see. I'll look at what most people. A lot of people really like C, so developing a plan of care. Definitely, we're not. The LVNs do not maintain the plan of care. The RN does. And yeah, Josh is actually correct as well on what he mentioned. That D is a trick question. They can reinforce it, but they're not doing the initial education. So it is not gonna. It is gonna be D because we cannot have them do that.
Do the education
Yeah.
on it. Like, if it said reinforcing education, then we can, but this is just saying educating them about all this stuff, and that is not okay.
So far we have A, C
C.
and D.
Yep.
Auscultating lung and bowel sounds, they're able to do that. They're not able to like interpret them, but they're able to come back to the RN and be like, hey, I auscultated the lung sounds and I heard something. You can come check it out or whatever.
Yeah, just not the initial one.
Yeah. Starting a blood transfusion, we're definitely not doing having them do that. That's not something that's in their scope. You need to have an RN, you need to have two RNs to kind of get all that started. G, administering IV morphine. Again, we're not, LVNs is not in their scope of practice to do IV pushes, so they're not going to be able to do that one. And also, like Josh mentioned, they are able to treat all stages of
Pressure injury.
pressure injury. So that is something that is within their scope.
So final answer is
Yeah, so the final answer is going to be A, C, D, F, and G. Yeah. Is that good with everyone? We understand everything here that's going on here. Yeah, for me, it was always the
having one of those moments. I don't know why that reminded me of that meme.
I don't even know that one. Yes. Yeah, but just for me, there was always the LVN questions I got that was like confused. God, what can't they do? Okay, next one. In your unit, there are two RNs. One is a new RN, new grad, while the other is an experienced RN. In addition, there are three LVNs and two nursing assistants. Which task delegated to one of the nursing assistants by the new RN needs to be reevaluated. So basically, you
Yeah.
have a new grad, and he delegated something. Which one do you think, like, hey, maybe don't do that?
Maybe no.
No worries, Ryan. And again, this is select all that apply. These are all going to be select all apply unless something says otherwise.
Question, where were we at?
Number two would be, I mean,
Probably, yeah.
probably yeah.
I think a lot of the delegation ones end up being more knowledge based. Whereas your prioritization is not as much knowledge based, but your delegation I always felt like was more knowledge based. So you have to know what is possible for each person to do and what they can't do.
Let's see. I'll wait for one or two more people to give answers, and then okay, so we have enough stuff on here. Um, pretty much everyone agreed it's A and B. So why can we not do this? So what are things that TNAs can't do? They can't do medication. So hydrocortisone, even though it's a cream, it's a medication, and it's not within their scope. And then the fleet enema. Fleet enema is actually again like a medicated enema, so it's another thing that they cannot do. If it was just like a normal enema, I believe that is within their scope. But because it's specifically oh bye Bella. Because it's specifically like medicated, then it's not something that they can do. Everything else is within their scope. Definitely something you'll see a lot is ambulation, taking their vital signs, all that's good. Emptying the ostomy bag. So I know private caregiving is different. Probably, yeah.
Oh, yeah. A lot of times what you see in hospital versus or like acute care, subacute care, home health, it's all gonna change stuff. A lot of times for the questions that you're being provided though, it focuses a lot more on purely acute hospital care. But that's definitely something important to note, Josh.
Yep.
I think we're done with this one, right?
Yep.
Okay, cool.
So I'm just manipulating the mirror.
Manipulating the mouse.
Yeah.
Wow.
So I'll zoom out just so that we can
Mm,
blink. Oh wow, why'd you make them so long?
I'm sorry. I think this one would be good if you just go like true or false. Is this
Yeah,
correct or
probably.
not correct?
When delegating, you know that as an RN, you must follow the 5 rights of delegation to make sure you're delegating properly. Give the 5 rights of delegation. Oh, this one, you guys can do it. Like, you guys got this.
So if there's anyone that selects four answers, you might want to
Yeah.
reconsider. Boo-doo-boo-doo.
Yeah, so we got all the answers. So again, we talked about right direction or communication, right supervision. We need to have the right task, the right person, as well as the right circumstance. So I gave you a hard time, Keelan, but that was actually a fine question. I just saw the numbers of stuff. I'm like confusing myself.
I do know, I think that happened to some people in our class where they were like, five rights of delegation, but they were thinking med admin. It happens. There's five rights of this, five rights of that. It's bound to get confuzzled at one point or another, right? That's my thought.
All right, so number 5 is a true or false. So
We love that.
we love that. An RN delegates to the LVN to administer a scheduled feeding to a patient. The RN now transferred full accountability to the LVN for the task getting done, and the RN is no longer accountable for the task. True or false? And this is again something that is we directly talked about is that the RN is going to be accountable, held accountable. You give up your how you say what's the word? What's like the exact that you're giving? Like there's like a specific like the specific phrasing because you remain
Oh,
accountable. You transfer the it's kind of weird because it's like you're transferring the responsibility of the task, but you are remaining accountable for how it was done or if it was done at all.
pretty much.
So kind of so it's like you're still responsible overall for it, but the task being done is exactly your license is on the line.
Darn right.
So if for nothing else, that's if for nothing, even if you hate delegating or you hate charting or you hate doing all that stuff, it's for yourself, like to protect yourself. Because if it comes around 5 years later, they'll look at your documentation and you're like trolling, and then you're getting in jail or something. Then
Oh, bro. Yeah, I think they got
yeah,
that.
I'll zoom back in because I think an RN has a critical patient that needs constant monitoring. However, the RN also has other patients in need of care, which tasks can be delegated to the LVN so that the RN has an easier time. All right, we got enough answers. But yeah. Again, this is just kind of eliminating the stuff that's not within their scope. They're not going to be admitting or assessing a new admission. They're not going to be doing discharge teaching because again, they can't do that initial teaching. They're not going to be working on things involving the care plan. They can give subacute heparin, that's within their scope. Putting in the leads for the EKG, definitely within their scope. Taking the stool specimen, again, that's within their scope. Anything related to like a central line is not going to be within their scope. So they're not going to be touching the central lines. All right, so pretty. All right, so this one is not going to be a SATA, or maybe it is actually. I think it is. Yeah, it is. It's still a SATA. Sorry, if it doesn't say, if it says not SATA, then it's not a SATA. But this, so which patients below are best assigned to the LVN? Yeah, exactly. So again, looking at a blood transfusion, that's not within the scope. So again, we're just trying to really hammer in that you should know the scope of the LVN so that you know what they can and cannot do. Are they able to help us with assistance performing range of motion exercises and ambulating with a walker? You are. So I know something that I think came up as one of our classes was that someone, I think maybe like someone might have read this question and be like, oh, wouldn't it be best to have the CNA do B instead? And technically, yeah, the CNA can do B, but is there a CNA in the question? That's kind of what came up there. But don't add on to the question. If there's no mention of a CNA, just imagine that it's just you and your LVN. Does that make sense? But don't kind of like gaslight yourself
Gaslight
into
your boss.
into like adding on to the question. Yeah. So the CNA can also do yeah. But let's say in this situation you don't have a CNA because the question didn't mention CNA, so don't create one. So in this case, B, even though the CNA can do this, we only have an LVN, so we're just gonna have the LVN do it. And then C, they are post-op day 6. They're pretty stable. There's probably just only like routine stuff going on. The LVN can definitely take care of this patient. Meanwhile, this person has chest pain, ST elevation. This person's not stable.
Keep
This
going
person
downhill real quick.
needs to go get like a PCI
Real quick.
real quick. We're gonna
Real
do
quick.
Mona, get the PCI.
Right.
Yeah, pray. All right. See, there's a there,
Sorry.
girl,
Girl. Why are
girl.
you so mean? This one's also, oh
Yeah,
yeah, it says select all the tasks.
yeah. Select all the tasks you would delegate to a nursing assistant. So that's a CNA as the RN. I guess can you guys see the whole pic?
Yeah.
There's some extra stuff. What can the CNA do?
What is denture paste? Help
Oh
the
yeah,
stick, yeah.
yeah, pretty much.
Smacked it on up there.
It's like glue for the dentures. All right, we have enough answers, right? Pretty much. It's a bit more. This one's a little straightforward. So the CNA, can they do wound dressing changes? No, that's not within their
No.
scope. Can they do IV flushes? Definitely not. Can
Nar.
they do vital signs? Yes. Can they weigh the patient? Yes. Can they do mouth care? Yep. Can they suction? No, that's more invasive. They can't do that. So wound care, and suctioning invasive.
Oh, I like that. Any
Yeah,
type of treatment UAP can't do. I like that.
yeah. Applying oxygen um
To the
to the
patient.
patient, technically no.
Because it's a med.
Yeah, it's considered a med. Will they do it in real life? Yeah. The RNM will be like, oh, CNA, connect this real quick. But in according to literature, they should not be because it's considered a med. It's technically without, it's not in their scope, but they do it all the time. But again, it's not within their scope, so it's not something we can delegate. So not going to be G. Age, assisting a patient, connecting a patient to their IV fluids. Is that something within their scope? No. Will they do it? Probably. The RN will probably in real life delegate, be like, hey, connect this real quick. Um, like maybe they disconnected it temporarily so they can pee, and they'll have the CNA be like, oh, when you're putting them back in bed, just reconnect them to their they reconnect them to their IV and restart. Yeah, but in real life that will happen. But for this, try to keep it with
Book.
try to keep it with the book because that's how they're gonna go off. That's where your experience can hurt you because I'm sure you'll see this happen a lot. Yeah.
Oh, girl, yeah, I have seen it a lot. Thought in first
Um,
semester, I was like, oh, cool.
yeah,
Yeah, for testing purposes, just know that you can't.
yeah.
They can't technically do it.
Assisting a patient with the bath course and the denture paste. Yeah. So all of that.
Like,
Yeah, you guys are doing a really good job on that. So this is your first not SATA.
from here on out, it's not SATA.
Okay, great.
I wanted to be nice at the end of it. I had a change of heart.
Wow.
I
All right.
know.
After a change of shift, you are assigned care for the following patients. Which patient should you assess first? What is your highest priority?
Who finna die first?
My laptop at this point.
Yeah, actually, you got 14% on your laptop. 14% in a dream. Well, if yours dies, I have my laptop on the side because
Yeah.
I'm technically a part of the meeting still, so we make do.
Yeah, pretty much. So let's look at all this. So patient on a ventilator, approved spiral sputum specimen must be sent to the lab. Is that your highest priority
Oh,
base?
she's chilling.
Yeah, that'll be fine. Patient with COPD, their pulse ox is 90%. They're good.
B is
It's expected.
expected.
Yeah. They have COPD. We expect that. That's a great number. Great. Good for you,
You're
sir.
doing great, sir.
Person with pneumonia that needs IV antibiotics, expected thing, pretty stable. Nothing here in
The
the
only
first three lets us know that like, oh my God, they're gonna die.
Yeah, the only other thing I would say is with C though, because your IV antibiotics usually need to be administered like
Yeah,
within a very specific time frame. So you might have questions where it's like a time constraint issue if it's not anything else. But then we look at D. Yeah, yeah.
yeah,
I was like, we
yeah,
got someone who had a bronchodilator, had treatment, and they're still experiencing shortness of breath. So we have airway breathing issue there.
yeah. We're scared.
Yeah, we're scared.
We're scared. Hell.
But that was something I wanted to note with the IV antibiotics is that sometimes like, oh,
Ooh,
oh, okay, so DCBA pretty much,
pretty much.
or maybe AB.
Maybe A, B, yeah.
That would be like maybe the only thing at the end, but pretty much,
Yeah,
yeah.
yeah, 'cause B is pretty stable, like expected super stable. And this is like a
We need
test.
to do, yeah, a task. But yeah, solid.
Solid stuff. Next one. Charge nurse is making assignments for the next shift. Which patient should be assigned to the fairly new nurse? 6 months experience, both from the surgical unit to the medical unit. Yeah,
And that was a
perfect.
really quick influx.
Yeah, but it's not the saddest, you guys go crazy.
It's so easy.
Pretty much, honestly, yeah.
I'm trying my best to make these questions. But we kind of just want to but kind of just drilling down
Yeah.
a lot of the stuff because I feel that sometimes it could be difficult when we see these questions come up where it's like oh, like this nurse is being moved from the which one is it called? The bone one, the
Yeah,
ortho department. All of a sudden they're getting moved to the ICU. Is that ever gonna happen? No, but that's just an example. They're getting moved to the ICU. That sucks. What patient am I gonna give them? It's gonna be like someone on traction or something. Give them an ortho patient. You want to give a new nurse the most stable patient as well, because
exactly.
this is somebody with not a lot of experience. They're still learning the ropes. So I don't want to overwhelm them and put them with an unstable patient that could have a sudden change in condition.
Yeah.
Um, yeah, but it's just kind of so that you guys have the idea of like the types of questions that may come up essentially. But yeah,
Pretty much, yeah.
yeah. So see, because Miss Girl, we can even do that.
Yeah, literally.
Then on to number 11, the nurse plans care, because you sound like you're dying with your nose. The nurse plans care for a client in the post anesthesia care unit as your PACU. Which of the following should the nurse assess first? And this is not a SATA. Yeah, it was like pretty much. It's pretty straight up, but it's reinforcing.
Yeah, just reinforcing.
Yeah, I was like, everyone's gonna get this because we want to reinforce that our ABCs. I want to assess our respiratory status, especially because they're post anesthesia.
Because a lot of those anesthetic things that the things that put them under include things
Putting
that
them under.
yeah,
Sorry.
gonna lower your vital signs.
Yeah, so this was pretty straight up.
Pretty straightforward. We're almost done actually.
Let's
Again,
check those reflexes.
yeah. Again, this one's pretty straightforward in terms of like what we can really go over. Some of your questions, of course, there'll be things that really they'll might make you think a little bit on the actual test. Again, this is where like you guys go on nurse like look up questions on nurse
I
lab.
love nurse labs.
They have good questions
Nurse
on
labs look
that.
great.
Yeah, nurse lab is good.
Nurse labs. Sorry.
Nurse lab is great. Um, wherever else you might be able to get literally just Google
I think
questions.
nurse lab has like 100
Yeah,
questions.
they have a
So
lot of
it's
questions, so you got a lot of practice with this.
pikey, some of them are from here.
Oh, that ass?
Yeah.
Oh, okay.
Say that. But yeah. Where are we on now? 12?
Around 12.
Okay, so nurse Channing is caring for four
What kind of is
clients.
that?
I don't know, Channing Tatum. Why are you asking him about his name? That's mean. That's what he was named with. He's caring for four clients and is preparing to do his initial rounds. Which client should the nurse assess first? And this is not a SATA. So you might have questions where it pops up like, who are you going to assess first? Which one's gonna die first, essentially? As morbid as that sounds. I like that you put it in the order.
Yeah.
Um, yeah. I think it's good practice as well. Like when you guys go back over the questions, um, going back and looking like, okay, I would do this one first, then this one second, and then come up with your rationale. Because, if you ever have to, I mean, in real life, you're gonna essentially
Yeah,
have to do
you're gonna
that.
have to do that.
It says client with a S. Wait, where?
Wait, wait. Here's just this client with a
Oh, I think it means the four clients up here.
oh,
Yeah, because I was like, if that's all four of your patients, like
yeah.
you're gonna have to figure that out.
Yeah.
You're gonna have to figure out who's dying first, who can die first, and who's most stable.
Yeah. Here it's just client without the S.
Yeah,
Where it actually has the country.
yeah.
Yeah, I agree with your order though. So B, the person is COPD, but we expect 84? We don't. So that's not a good number for even someone COPD, not a great number. Josh then put for his is D. So out of everything here, this person is being discharged today. They're pretty stable.
You said D. D's down here.
No, I know.
Oh, okay. I was like, what do you? Okay,
No, no. I'm just kind of comparing the other two.
okay. You
Yeah, so this one's pretty stable. This one has PT. Again, like pretty stable. We're just doing like a little thing. And this one, pressure ulcer, that needs a dressing change. Again, nothing really points out like they're unstable, but this dressing change could be like preventing infection and stuff. So I would prioritize preventing infection over kind of just like, okay, you're here getting discharged, and okay, let's get you some therapy,
I was gonna
physical
say
therapy.
the for CAPT, the only thing you might be doing alongside of that is pain medication. So based
Maybe.
off of what we had, it's
Yeah.
like safety, ABC, infection, pain
Pain.
at the very bottom. So
Yeah.
then,
Even then, it still kind of falls out of order.
yeah, no, that's what
Yeah.
I'm saying.
Oh yeah, yeah.
But in any case, so yeah, I like BDCA as a
Yeah, I like it too.
Beans.
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 The nurse employed in a long-term care facility is planning assignments for the clients on a nursing unit. Need to assign 4 clients and has LVN and 3 CNAs.
Dang.
Which client would most appropriately be assigned to the LVN? So let's see.
I think this is our last question.
It
Is this
is.
our last question?
This one's pretty obvious.
Well, I'm sorry, sir. It's been a long week.
Yeah,
I
fair.
did some of these when I was sick, if I'm being
Oh,
honest. So my mental status was like, yeah, these are hard questions. I'm trying to think too actually.
yeah, stuff like that is really just again really hammering in how what you really need to know is like really understand the scope of the CNA, understand the scope of the LVN. At least according to the book, I know we have LVNs here, and I know that I'm sure you see both CNAs and yourselves doing things that you're technically not supposed to do in
Okay,
practice, but
straight.
just kind of go with what the book is, and they do kind of break it down in the
Well, that's at
literature.
the
I
hospital.
know.
True.
I know.
True. They be trying to be like, hey, can you do this, please?
Pretty
Like
much.
I remember one of our classmates was the only one in our clinical group to speak Spanish, and a lot of the
Oh,
nurses on the
yeah.
floor did not
That
speak
that yeah,
Spanish.
they did that for me too.
Yep. So they'll be like, hey, can you translate for the doctor? And it's like,
Yeah, that
no,
they did I did that in the evening. It was like, "Thank you."
don't admit to that on camera.
I mean, I help.
Yeah,
Uh,
but that happens a lot. Let's be real. This is gonna happen a
no,
lot.
yeah, it's gonna happen.
But yeah, in any case, so what is it? Like do as you're told, not as you see.
Yeah,
Something,
something
whatever
like
like
that.
that.
Yeah, and then, of course, your, rights of delegation, and then from there on out, it's just really those practice questions on, um, nurse labs, I think is gonna be really
Yeah.
helpful because they have so many questions for that.
I think there's because our delegation is I forgot who mentioned it earlier that it's
Yeah, I'll give
really
you
no
this PDF.
that is really knowledge based for your delegation. But your prioritization tends to not be as straightforward. It's
Yeah,
not really as knowledge based. You have to have a baseline knowledge of the conditions, but beyond that, you have to determine, okay, what's gonna happen next? What's gonna happen if I don't do something with this patient? So that's where your critical thinking comes more into play. So I would, try to put more attention on your prioritization. Just so that you guys can really understand the concepts and
yeah,
who you're gonna see first, why and why.
yep,
But yeah, beyond that, I think that is all we have for you today.
and the recording.
I didn't really